Good morning, everyone. Continuing from Dr. Chitra's presentation, for this week from 7th of February to 13th of February. First case, I thought of starting, we've been presenting clinical cases followed by the AST pattern. So here we'll be seeing the AST pattern followed by the clinical case. So we have two blood cultures, both of which is flagged positive for Candida glabrata, received on the 9th and reported on the 12th. So we'll just have a look at who this patient is. We have a 57-year-old patient, male patient with diabetes and hypertension. He presented with symptoms of vertigo, vomiting, and an ataxic gait, and had a tendency to fall on the left. So he had a acute cerebellar infarct on imaging and was thrombolized with tenecteplase. On day 3 after this, he further deteriorated and started a decrease in GCS, sensorium dropped, and he developed a new right-sided weakness which was not present initially, due to which he had to taken up for a neurosurgical procedure of extraventricular brain and posterior fossa decompressive craniectomy. So there was brainstem compression and hydrocephalus in this patient. So we'll be discussing the further his course in the hospital, what all multi-drug resistant bugs he got. He was on mechanical ventilator for almost 10 days. Now they are planning to discharge him. So these are the list of cultures sent and growth obtained. So we were able to see the chronology from 26th of last month to 9th of this month. So the latest two cultures, which is from the 9th of this month, group Candida glabrata. So 8 days prior to this, when it was initially sent, also we had Candida glabrata. 2 ET aspirates prior to this, almost 2 weeks back, grew Klebsiella pneumoniae, which was susceptible to carbapenems, and it also grew carbapenem resistant Acinetobacter baumannii. Prior to that, the CSF had no growth, and the urine also grew carbapenem resistant Klebsiella pneumoniae. So in this, the urine carbapenem resistant Klebsiella pneumoniae wasn't treated. Patient did not have any symptoms, or the urine examination suggestive of urinary tract infection. The ET aspirate for the Klebsiella pneumoniae was treated, and the crab wasn't treated. So these are the list of antibiotics that he had received prior to this Candida glabrata report. So now we started on injection caspofungin with a loading dose of 70 mg, followed by maintenance dose of 50 mg. So we have been repeatedly getting queries from the clinical side. Now he's almost 7 days of caspofungin 7 to 8 days of caspofungin is over, and they want to switch to fluconazole since patient is improving clinically and they want to discharge the patient also. So can we do this? So this is the 12-point candidemia footnote from our department which we have sent. We'll quickly go through each point, and this is taken from the 2016 IDSA guidelines for candidemia. So the initial loading dose was told. So if you look at the dosing regimen, we have loading dose for caspofungin and anidulafungin, whereas we don't have a loading dose for micafungin, because the order of kinetics varies between micafungin when compared to caspofungin and anidulafungin. So a front loading dosing is not required. So that is the important thing which we have to look. When it comes to fluconazole, for Candida glabrata, following this discussion, I have included discussions from the UCAST table and the CLSI table for Candida glabrata. So we look at why we have to give high dose fluconazole and not the normal dose of fluconazole. Almost 12 mg per kg, 800 mg per day has to be administered in these cases. Important aspect with respect to treatment and monitoring in this case is there are two organisms, candidemia and bloodstream infection caused by Staphylococcus aureus, where they have metastatic potential, and repeat blood cultures every 48 to 72 hours is warranted to look for microbiological clearance. We will also have to do ophthalmological examination. We also have to rule out infective endocarditis, osteomyelitis. All these metastatic complications have to be ruled out. So after it has been ruled out and got microbiological clearance, treatment for almost 2 weeks is required. So this is with respect to this case. Now patient is improving clinically. Coming to our UCAST and CLSI guidelines. So this UCAST guidelines for candemia is the latest document 2025 released last June. If you are able to see for Candida glabrata, so this is the table for Candida glabrata. You have breakpoints for mica fungin, it is available. So whatever is given in yellow, it means it is update in the new document. So you have an update for Candida auris, and see here you have a new breakpoint for mica fungin. It is given here. You have a breakpoint for anidula fungin. For caspofungin, specific breakpoint is not there. We'll see why is it so in the comments. And with respect to fluconazole, do you have a breakpoint? Yes, you have a breakpoint, but you have a comment to read as well. So we'll look at what those comments are. So this is only with respect to glabrata. So isolates that are susceptible to anidula fungin as well as mica fungin should be considered susceptible to caspofungin. So this is what a mica fungin is until caspofungin breakpoints have been established. So as of now, we don't have clinical breakpoints for caspofungin from UCAST because there is significant interlaboratory variation in the MICs for caspofungin. When it comes to fluconazole, because here in our case this is pertinent because the clinicians are asking for a step down therapy when the patient is getting discharged. So all Candida glabrata wild type strains should be considered in the intermediate category. This is verbatim from the UCAST document. So MICs of Candida glabrata should be interpreted as resistant when it is above 16 mg per liter, and susceptible category of less than 0.001 mg per liter is just to avoid the misclassification of wild type strains as susceptible strains. So even though we have a wild type strain, should be considered as intermediate, and a high dosing of fluconazole should be opted for if you are planning for a step down therapy. Always echinocandin first and later look for the step down. So this is the CLSI counterpart when it comes to the AFST testing for yeast. This is the document released in 2022, M27. This is M27, M44 document. So here you are able to see the breakpoints for Candida glabrata. For anidula fungin it is given. Caspofungin, do they have a breakpoint? In UCAST they do have a breakpoint. Again, in mica fungin, they do have a breakpoint. So if you are able to see the breakpoints of mica fungin are less compared to that of anidula fungin and caspofungin. But is it significant? We'll see. For fluconazole, if you see here, they mentioned this correlates with the UCAST breakpoint, saying that it is susceptible dose dependent. It has to be given at a higher doses and you shouldn't report it as susceptible. So coming to the verbatim comments from the CLSI document for Candida glabrata. So the selected breakpoints have been established to distinguish resistant variants from susceptible isolates. So difference in breakpoints reflect methodological issues. Due to in vitro methodological issues, the breakpoint of mica fungin against Candida glabrata is lower than that of other echinocandin. We saw it is a dilution lesser, right? Less than 0.06, whereas there it was 0.125. But this does not reflect any inherent clinical differences in efficacy. So when it comes to efficacy wise, this is just a methodological difference in the breakpoints when it comes to the lab. Clinically, there is no inherent difference between the echinocandins in this case. So for Candida glabrata and voriconazole in this case, current data is insufficient to come up with clinical outcome based susceptibility testing breakpoints. So this is with respect to Candida glabrata alone. So what is the new name of Candida glabrata? Candida glabrata has been renamed as Nikhil glabrata. This is the in vitro susceptibility pattern of most of the Candida isolates. So whenever you are reporting a Candida isolate, especially from sterile samples like blood, you have to look in at the intrinsic resistance pattern. So here you are able to see for glabrata, with respect to fluconazole, the MICs are higher. Strictly resistant, you have agents like Candida krusei, Candida novogenesis, inconspicua. When it comes to liposomal amphotericin B, where centers go for liposomal amphotericin B, you have to, here is it given, you have to look at isolates like Candida lusitaniae, which are higher MICs for amphotericin B, it has to be looked at. So this is a recent document as to why this renaming of Candida glabrata has come out, because Candida glabrata on phylogenetical analysis has seen to be more closely related to Saccharomyces species rather than your Candida genus. So that is why they want to put it into the Acaciomyces clade rather than the Candida clade. So it is more of a phylogenetical reason rather than a clinical and public health reason. So coming to our next case, here we have a.
So what is your ultimate suggestion would be? Should you downgrade to fluconazole or not?
Sir, if there are no signs of metastatic involvement, patient is improving, and patient should at least should have received caspofungin for a period of 7 to 10 days inside the hospital, sir. Sir?
From when?
After a microbiological clearance.
Yes. So here it is 9th. The last one flat down 9th.
9th, sir. So after, now we have 5-6 days, sir. So ideally after 14 days, sir. But here in this case,
repeat blood culture has been sent.
Repeat blood culture sent, sir, not yet flagged, sir.
This patient had one Sanderline, sir. And Sanderline also flagged positive. So they have removed the Sanderline. So it was not clean their removal. After that also they have sent.
So the paired blood cultures both
We
grew,
need
sir.
to wait at that presently, no?
Yes, sir.
That whether it is coming negative or not, we need to wait. Then we can have a rediscussion whether to start fluconazole or not.
So coming to our next case, the last case of a metastatic infection, we saw Candida. Again, this is the other metastatic bloodstream infection, which is MRSA. Here this is a MRSA isolate. Here there is no inducible clindamycin resistant isolate. Only one sample was sent. It is a pediatric patient, 8-year-old. So here you are able to see the breakpoint to MIC quotients of teicoplanin, which sir has been repeatedly telling us is always better than vancomycin in our hospitals isolates. So we have an 8-year-old female patient, fever for 10 days. She had 2 episodes of an urticarial rash, one 15 days prior and one a week prior. Patient had significant thrombocytopenia. Manual platelet count was between 2000 to 6000. So they was thinking immune thrombocytopenic purpura. They had the other DD of sepsis induced thrombocytopenia as well. Patient as such has no baseline immunocompromised state or any other comorbidities. The points against idiopathic thrombocytopenic purpura, or the new name immune thrombocytopenic purpura, is that patient rapidly improved with antibiotics and platelet transfusions of RDP and SDP. No steroids are administered. Usually in ITP, even if you give platelets, it is not indicated in ITP to give platelets. So even after giving platelets, this patient improved and also improved well with antibiotics. Treatment for ITP is usually you start them with steroids. Here there is no steroid administration. So with correct antibiotics and appropriate platelet management, the patient improved drastically. Here you are able to see the CBC pattern of the patient from 6th, 10th and 12th. So initially there was increase in TLC of 12,000, platelet was only 2,000, drastically decreased. So with appropriate antibiotics and platelets, TLC decreased, platelet count increased to 55,000, it continues to increase, it has crossed 150,000. There is a slight increase in the TLC count here, but they have not considered it to be due to infection rather than a reactive change. The procal of the patient has decreased. The procal for this date continues to be normal. The earlier procal was increased. On 12th, it is decreased, and there are no fever spikes, and the patient is improving clinically and is hemodynamically stable. So these are the list of antibiotics the patient has received till date. Amoxiclav and peptides were given outside, so dosing is not available. Empirically started on meropenem, vancomycin and doxycycline. Meropenem for broad spectrum gram negative, vancomycin for broad spectrum gram positive, and doxycycline for atypical pathogens. Now meropenem and vancomycin has been, meropenem and doxycycline has been stopped. So this dosing of vancomycin, a TDS dosing of 20 mg per kg per dose, almost amounts to 60 mg per day. Do you think this is the required dose, or is it overkill or underkill? Usually we say 1 gram BD when it comes to the adult dosing, right? So let's look at this whether it is overkill or underkill. So we have our 2025 pediatric antimicrobial therapy guidelines from Nelson's Pediatrics. So here they specifically mentioned that for invasive MRSA infections, in order to achieve your correct AUC by MIC of 400 to 600, you will have to give a high dosing of 60 to 80 mg per kg per day. Here we are following a 60 mg dosing pattern. It has to be given 4 or 3 times a day. It should be divided into 3 or 4 doses. So this has to be followed specifically when it comes to invasive infections, and this pattern has to be followed when it comes to these pediatric populations. So the role for teicoplanin. So again, as Sir repeatedly emphasizes, so these guidelines are usually from the Western population where vancomycin is more aggressively used rather than teicoplanin.
American Academy of Pediatrics.
AAP, sir.
That's why Tico is not approved.
So here teicoplanin would have a better PKPD parameter because it has a better BMQ profile here, and it has a less nephrotoxic profile for the patient.
The role of teicoplanin is not studied in European countries also. No?
Yes, sir. So
Not much data is available for pediatric age.
So looking back at the history of teicoplanin, sir, going and looking how teicoplanin was isolated. The irony is that teicoplanin was isolated from a soil in India, sir. Somewhere near Pune, they have isolated teicoplanin, sir. So I think we should come up with some guidelines for teicoplanin. Sir. So the patient improved with this correct PKPD dosing. There were no new fever spikes over the last 4 to 5 days. The patient was being monitored extensively. So looking at this patient retrospectively, patient had proper MRSA bloodstream infection. Usual MRSA bloodstream infections, what we read of is there will be some soft tissue infection can be there, an abscess can be formed. There can be sometimes even an eschar can be formed because of the PVL toxin. This is a leukocytal dermonecrotic. But why urticarial rash in this patient? Patient does not have any other similar episodes prior. So looking at some of the atypical manifestations of MRSA invasive infection. So this was a paper published in the Indian Journal of Dermatology, where the role of nasal carriage of Staphylococcus aureus was seen in patients with chronic urticaria. So this study came to a conclusion that people with higher rates of nasal carriage of Staphylococcus aureus turned out to be an etiological risk factor for chronic urticaria. So this also can be looked into as one of the atypical manifestations of an invasive bacterial infection due to Staphylococcus aureus. So now we're done with 2 pathogens, both having disseminative potential. We'll look at a case where it is less of a pathogen. This is an
In that case, echo finding normal.
Sir, in both the cases, echo and ophthalmological findings were normal. No bone pain, no bone involvement also, sir. Coming to our third case, moving over from pathogens to a less likely pathogen. We have an 18-year-old female presents with fever for 5 days, sore throat for 7 to 8 days. The patient is being treated on an OPD basis. It was treated as pharyngitis because of the prolonged duration of fever. Blood culture was sent. It was a single sample sent. We grew this organism on blood culture. They were able to see this golden yellow colonies, but it was not a GPC, it was a GPB. It was in certain places it was pleomorphic, had coccobacillary appearance. So on Malditoff, it turned out to be Exiguobacterium auranticum. It's an aerobic motile non-spore forming gram-positive short coroniform rod. It is catalase and DNase positive, oxidase negative. So this has a unique property of growing at a pH of even 10 in nutrient agar. It is and at a NaCl percentage of 6, which is again makes it halo tolerant. So in such cases, sore throat, patient comes to your OPD because sore throat is a common presentation in the OPD. What warrants the administration of antibiotics to take a call whether you will give an antibiotic or not? Is there anything we can look at? Do we have a system or a scoring profile? So we have this modified Centaur score or MEC-ISAC score, which can be used to determine, especially in the OPD basis, as whether to administer antibiotics or not. So you have the patient's age must be older than 3 years, cough absent, because cough they consider more of a viral component, more of dry cough, exudative or swollen tonsils will give you +1, cervical lymphadenopathy +1, temperature of more than 38 +1, age again less than 15 years of age, and rarely if patient is more than 45 you get minus points. So a score of 4 warrants a high likelihood of streptococcal pyogenes pharyngitis, and you recommend empirical antimicrobial therapy with culture and rapid POCT testing. For a score of less than 1, there is less likelihood and you needn't test. The score is 2 to 3, you can recommend for the POCT test with culture. So this was again looking into the organism Exiguobacterium auranticum. Like, are there case reports, are there patients whom we should really look into when this organism is isolated? So this has been isolated from bloodstream infections, it has been isolated from corneal ulcers, it has been isolated from patients with pneumonia. This is a relatively susceptible organism with good MICs, very low MICs for penicillin, meropenem, gentamicin, ciproflox, rifampicin, vanco, tetracycline, erythromycin and clindamycin. So here in this study they were able to isolate from 2 places, one an environmental source and one from the patient. The environmental source was the distilled water filters in the hospital, and the patient source was the patient from the bloodstream, had a bloodstream infection post prostatectomy. So again in prostatectomy there is a lot of installation of fluids when the TURP procedure is being done. So these are the potential areas through which, like when you're doing TURP, there will be break in the barrier. You are instilling a lot of fluids for irrigation. So these sources should be looked into, and immunocompromised patients should be treated if the patient is symptomatic again in this case. So in this week's list of blood cultures, we totally had 150 bottles. Of the 150 bottles, we only had 3 contaminants, one Staphylococcus epidermidis, one Corynebacterium simulans, and this Exiguobacterium auranticum. This patient wasn't treated on any antibiotics, was managed symptomatically through OPD basis. So 3 by 150, this gives us a total contamination of 2%, which is again less than 3%, comparable with that of the CLSI standards. Thank you.